Hello, my name is Mick Helvers. I'm a registered nurse for Kuwait Delta and I work on the progressive critical care floor, and I am a doctoral candidate with Brandman University. I am here to present my education plan for my upcoming clinical scholarly project. The purpose of this project is to seek to implement prediction-based models and telehealth into transitional care for congestive heart failure (CHF) patients to determine if these measures can prevent unnecessary readmissions after an index hospital stay. The implementation of such a plan will require education of many stakeholders, whether it be to help administration understand why such a measure is both necessary and cost effective, or it be to provide education on how to implement the plan to clinical staff. Education is going to be necessary. The first section is about the stakeholders. I have broken down my stakeholders into three primary segments. Administrative, which is comprised of financial, information technology, otherwise known as IT, and risk management stakeholders. The local community, which is comprised of patients and their families, and the public at large, and finally clinical, which is comprised of medical providers, nurses, nursing assistants, and clerical staff. My plan for administrative staff education. The role of staff related to financially initially will be educated to ensure that the implementation of my plan is cost effective. A plan is considered most effective if the benefits outweigh the costs. The educational needs of those stakeholders are to understand how my plan is cost effective so that they can support its implementation, and also to educate their staff on how costs will be collected. Methodological case studies have shown that prediction-based models will on average decrease readmission rates for CHF patients and reduce costs about 3.8%. Although less research, telehealth has been shown to decrease readmission rates by as much as 50%, while introducing very new costs. Statistical data stratified from the American Heart Association, Medicare, and the Kuwait Delta Healthcare District financial data, along with data from the Journal of American College of Cardiology, suggests that Kuwait Delta accrues over $9 million each year related to CHF readmissions. The measures I seek to implement have potential to save up to $1.4 million. So, $1.4 million of that $9 million due to less readmissions for CHF. The role of IT, although vital, is somewhat simpler than other staff. They will upload and maintain software used for prediction-based models into central servers. Their education needs are limited to additional knowledge necessary to add this to the list of programs that they already maintain. The role of risk management is to determine if the implementation of my plan is done so safely and effectively. Education provided would include results of literature review on the subjects of CHF readmission, transitional care, and risks related to the implementation measures. A literature review of telehealth used for transitional care of CHF patients shows that telehealth measures seems to have no significant impact on readmission rates. However, this information suggests these measures will prompt necessary readmissions and prevent avoidable mortality. You see my attached script for sources. One central theme identified among nearly all studies related to telehealth transitional care was that telehealth was less effective among patients who are higher risk for readmission. Therefore, use of prediction models to place risk on patients should result in better placement of telehealth measures to patients so that they will be effective with their transitional care while having more stringent measures for high-risk patients. Prediction models use dozens of parameters linked to readmission rates for CHF and can help identify patients at differing risk levels to help determine which patients should have the most resources allocated. The local community education plan. The role of patients, if they so choose, is to take part in the appropriate transitional care to prevent unnecessary readmission. Their educational needs, if they choose to take part in the study, is how the information will be collected and used and what their personal transitional care plan will be. The role of the patient's families is to provide support for the patients in their transitional care process. This can mean physical, emotional, and spiritual support. Families will need the same education that patients will need to best take part as their role in support. Finally, as Kuwait Delta is a community hospital, the public always plays a large role in changes being brought about. Therefore, although they play no direct role in this program, they will still be considered. Their education needs are to understand why we are studying the costs and effects of differing transitional cares and how it can benefit them and the community in the near future. The clinical staff education plan. So we're moving on to the third portion. We've discussed the community education plan and the administrative staff education plan. Clinical staff are perhaps the most important segment to determine the success or failure of my project. Burke and Coleman, in a 2013 expert opinion paper, identified 5 educational strategies that are required to successfully create new interventions for transitional care for chronic disease patients. And one of their 5 was the structuring of a cohesive team. And I believe that to do so, each member of this clinical team must have adequate education. The first role I will discuss is also the first to play a role in my program, nurse case managers. Case managers will identify patients in need for transitional care. In this case, any patient admitted with a primary or contributing diagnosis of CHF. Case managers can work with unit staff to identify these patients and can recruit them to the study. The educational needs of case management include helping them understand the resources available to the patients, how we can use the prediction model to determine risk for readmission, and what transitional care interventions are appropriate for each level of risk. The next role I'll discuss is the chronic disease nurse manager, which will provide useful input, support, and disseminate information so that all staff are on the same page. The chronic disease nurse manager is the nurse manager of the chronic disease clinic. I will be working primarily with the chronic disease clinic as they maintain transitional care for patients with chronic disease. Specifically, CHF is one of their primary goals. I think this is the perfect opportunity to get people on the same page and to work together to increase transitional care effectiveness if possible. So that's why the chronic disease nurse manager is going to play a large role in helping to support this intervention. To perform their role, the chronic disease manager will need to have knowledge of the telehealth interventions we will be using and the prediction analysis software and how it can help to identify a patient's risk levels. The role of registered nurses in the chronic disease clinic is the most versatile. Each individual patient will have care that tailors to their needs, and the interventions identified that coincide with the patient's risk. Patients at high risk may necessitate frequent visits by home health nurses and nurse-driven care. However, patients at low risk may be eligible to have patient-driven care, such as remote communication and monitoring, such as network-linked scales or daily health-related entries on a healthcare website. If it is deemed that a patient can drive their own care, it is the responsibility of the RN to educate the patient and communicate with the patient and the physician when necessary, such as when a patient has changes in weight or health status. In higher risk patients, of course, the RN will be playing a much larger role as they will direct care and likely be visiting the patient frequently. Although the RNs will not need training for interventions they are already familiar with, any new interventions and treatment methods need to be taught. Providers, whether they be medical doctors or nurse practitioners, MD or NP, will also play a role. It is the role of the provider to assign transitional care interventions based on each patient's risk. Although prediction-based model software will play a large influence in determining the best intervention pathway for patients, the final decisions will be up to the provider. The providers will need education on available interventions and information about risk management software so they can understand why each intervention is being recommended for each patient. Finally, there are nursing assistants, medical technicians, and administrative assistants to discuss. Staff and assistants positions will provide clinical and clerical support in ways that they already do. No large changes will be brought about in my project. However, they will still need education on how to access and use new software and how to understand the basics of prediction-based model software. So I've discussed all of the stakeholders involved with this project that I believe will be involved in the administrative, both the administrative, the public, and the clinical staff. To provide the education, I want to discuss the educational theory and conceptual framework I will be using. When discussing the topic of educational theory, and specifically the conceptual framework I would use in my education plan, it is important to understand why I have chosen to guide education with a conceptual framework. A conceptual framework is superior to unguided education as it provides structure, clear goals, and protocols to help ensure the education meets these goals, as well as the organization's philosophy and values. The learning theory that best applies to my project would be cognitive learning theory. In this method, it is accepted that the learner in this case the stakeholders, which already have background knowledge related to the subject, will use cognitive theory. With cognitive theory, um, it adds on to what people already have and then mixes with their current knowledge. So it would layer onto the knowledge they already currently have related to transitional care and readmission, and then it would add on to it. So if they'd never heard of prediction-based models, maybe that would be the new portion of education they would receive. Or if they were fully aware of that, but then they weren't aware that you could use a remote monitoring scale to determine if a patient's having weight changes and they should be readmitted, there's going to be something new to add to each person, and the idea behind cognitive learning is that each person will be able to add on to what they already know, take their current expertise, and they'll be able to share that with other people, and that way there would be an evenness of knowledge spread throughout. My goal is to meet the vision of Kui Delta and to meet their philosophies as well, to provide the best care for patients. My implementation plan. So I'm going to go through real quick how I feel my plan will be implemented. It is still subject to change and improvements, but this is the plan that I have so far. The first step for my implementation of my plan is to provide education I've discussed in this video to all of the stakeholders I've discussed in this video so that they can prepare for changes to transitional care. Now, when I say the stakeholders discussed in this video, I'm referring to the administrative staff and the clinical staff, the patients and the family and the public. Those educations will be provided once the plan has started to be implemented. The rest of the education needs to be provided before the plan begins. Once prediction-based model software has been installed by IT staff and all staff have been educated, all of the measures have been approved through financial and risk management channels, the project will begin as a double-blind, randomized controlled trial. Study subjects or patients will start their path with an index admit with a primary or secondary diagnosis of congestive heart failure or congestive heart failure exacerbation. When I say index admit, I'm referring to the first admit of the stay for the study. It can be a readmission in itself as long as it's not a patient who has already started with an index admit. So any index, meaning the first for the study, admission for CHF would be used. Exclusion criteria related to age and comorbidities is not planned at this time. However, it is a possibility to be explored, especially with patients who are unable to take part in patient-driven care due to diagnosis of dementia, history of drug abuse, or in cooperation with care. When a patient is admitted with this criteria, even if the admit is a readmission, the initial admit, known as the index admit, will be used for the study, as I once already stated. Once the patient is educated on the study, they will be randomly assigned to an intervention group and a control group, with stratification based on age, race, and gender if possible. It will be the responsibility of case management nurses to identify and recruit patients for the study. Once the patient is preparing for discharge, patients in the control group will be assigned transitional care using conventional methods. Patients in the intervention group will be assessed using prediction-based models, and patients with high risk of readmission will be assigned transitional care using nurse-driven care and frequent in-home follow-up. Patients eligible for low risk will be assigned patient-driven telehealth care methods, and patients in moderate risk will be assigned on a case-by-case basis. The patient will continually be recruited in the study over a 90-day period and will be tracked over an additional 90 days. This will require a total of 6 months to track all patient data. Patients will be tracked for readmission to the hospital for any reason, with measurements over 30, 60, and 90 days. Mortality and quality of life will also be tracked using qualitative and quantitative data. Finally, costs of intervention group and control group will be compared to determine if there is any effect on readmission rates, mortality rates, patient satisfaction, and cost-related transitional care. It is my hope and belief that the intervention group measurements will be higher than any measurement. To see sources for this presentation, there is an attached presentation script with all of my sources. There's several studies involved in the literature review I performed for the information I provided, and I can be contacted at mnhilvers, HIL, V as in Victor, ERS, @hotmail.com if you have any questions. Thank you.